Hello, my name is Alexandria Chute and I will be talking about how we can improve our practice to serve the benefit of our patients in relation to inadvertent intraoperative hypothermia or IIH. IIH is when a patient becomes hypothermic unintentionally during surgery. Hypothermia is when the core body temperature goes below 36 degrees Celsius. A reduction in 2 to 4 degrees Celsius is the average and anticipated loss of temperature during surgery. The most common factors relating to IIH is metabolic changes due to anesthetic drugs, which cause peripheral to core thermoregulation, low ambient temperature, heat loss from increased body surface exposure. These are additional risk factors for IIH. Why is there a current cause for concern? Patients are increasingly suffering from IIH. IIH majorly increases the patient's chances of acquiring an infection, increasing the length of wound healing time, surgical site bleeding, serious cardiac events, and increase the length of hospital stay. Ralph et al. Noted an increase in each of these adverse effects in a situational analysis, explaining why patients had longer hospital stays and why hospitals experienced resource depletion. The economy suffers as well. Currently, it is estimated that IIH costs the Australian economy $1.2 billion annually. Costs include the removal of people from the workplace, increased expenditure on resources, and increased need for hospital staff. If IIH was prevented, it would benefit the economy by more than $602 million annually. As nurses, we are obligated to use evidence-based practice when caring for our patients. The importance of evidence-based practice is to provide safe care, to make clinical decisions, and deliver person-centered care. These include the Code of Conduct, Code of Ethics, NSQHS standards, the ACORN standards, and Australian and New Zealand College of Anaesthetists guidelines. In relation to IIH, the current evidence-based practice for preventing hypothermia during surgery is adequate preoperative risk assessment, monitoring temperature preoperatively, recording temperature 30 minutes intraoperatively, active warming interventions such as warmed IV irrigation fluids, bear huggers and forced air warming, and also passive warming techniques, mainly through regulation of room temperature. This is my situational analysis and trying to find where the theory to practice gap lies. Risk assessment. Adequate risk assessment for the patient with hypothermia is required in order for the surgical team to implement appropriate strategies to prevent IIH. A study conducted by Duff et al. Found that 0.3% of participants were correctly risk assessed for hypothermia. This significantly increases the risk of IIH as targeted prevention techniques cannot be identified, thus they are not implemented. Monitoring. Evidence-based practice states that patients must have their temperature monitored 1 hour prior to surgery. However, according to Duff et al., only 58% of patients had their temperature recorded preoperatively, and of that, 9.8% of these patients were hypothermic already. In the intraoperative stage, 57% of patients had their temperature monitored every 30 minutes. A reason for this increase in documentation could be because, commonly during surgery, patients are continuously monitored, so it may be easier for clinicians to record this data. However, we can see that with an increase of monitoring, there is an increase in implementation of active warming interventions and thus a reduction of IIH. It is recorded that 55% of patients at risk of IIH are provided with intraoperative warming interventions. Additionally, only 10% of these patients are recorded to have received active warming. After implementation of active warming interventions, the rate of IIH reduces from 65% to 35%, which is a significant result, proving the efficacy of these best practice techniques. During the intraoperative stage, there is an increased rate of interventions due to the increased occurrence of monitoring the intraoperative stage. There are also passive warming techniques which prevent passive heat loss from the patient's skin. The non-compliance of best practice interventions shows that there is a significant gap between theory and practice. But why is there a theory to practice gap? Lack of knowledge. A qualitative study by Monday et al. Found that there was uncertainty and lack of knowledge in every single interview that they conducted regarding practice guidelines for perioperative hypothermia. Participants also felt like they were undereducated in the best practice interventions for the prevention of hypothermia and undereducated in the physiology of hypothermia and its risk factors. High turnover rates. Another current problem that may be overlooked in studies relating to IIH is the high rates of staff turnover. Australia has an estimated turnover rate of 15.1%. This estimation seems high, but this may be due to outliers like Northern Territory. High turnover rates are correlated with poorer health outcomes for patients and poorer quality of care. There are high numbers of staff who are inexperienced, thus they lack training, and this could reflect in high rates of IIH. There are unsafe work cultures. A safe working culture means that staff acknowledge and report when mistakes and poor conduct occur. A survey found that 77% of the MDT have seen negative behaviour in physicians. This correlates to possible bullying and lateral violence within the workforce. There is an existing hierarchy within the perioperative team. This power imbalance leads members of the MDT to not speak up when they do detect IIH and refrain from implementing warming strategies. Conflicts of interest. Different MDT members prioritize different aspects within the perioperative process, which often conflict with one another. Members of the perioperative team are undecided on who has the responsibility over maintaining the patient's temperature. What do we need to change? Nurses need to develop their surgical conscience, meaning they need to become stronger advocates for patients. The imbalance of the socio-cultural environment of the surgical MDT so that members of MDT have the confidence to speak up and intervene. We need to increase the rate of monitoring pre, intra, and post-surgery so we can identify points of intervention. And nurses and other MDT members also need to develop their knowledge of hypothermia and of the governing bodies of the surgical practice. How will we implement these changes? We need additional training, education programs, and mandatory courses. We need to have a team-based approach to education and training to reduce the conflict of interest in the surgical team. We need to create a safe and positive working culture by promoting the importance of mandatory incident reporting and implementing anti-bullying support systems. We need to encourage patient advocacy, and we also need to have hospitals audit annually for staff compliance of the guidelines.